Thanks, Greg. I am going to kick it off today and hopefully touch on some overarching concepts. If you don't mind putting my time, yeah, perfect, thank you. So that we make sure that we keep to timing, so we're going to allow to have some time for discussion. We'll make sure that we ask you some of the hard questions. I wanted to put up my disclosure slide just so that you guys know that I have a relationship with both all of the biologic companies and several of the instrument companies as well. I also wanted to make a quick congrats both to Greg for how successful this course has been over a decade plus, and to Doug, who runs the otology part of it. Really a well-run course that's focused on the practicals, and then the entire SSF team, led by Linda, but certainly the entirety of it. Greg and I Greg has been a very good friend of mine and taken me to see everything around here. I encourage all of you to take some opportunity to get out and see Seattle and the surrounding mountains. Always gorgeous when I come here, so thank you, Greg. The last acknowledgement I have is to the fellows at the University of British Columbia and the Vancouver General Hospital have helped me put together the images and videos you're going to see today, one of whom is here with me, and several others now spread across the globe having their own rhinology and endoscopic skull-based surgery practices. You know, I'll tell you that the disclaimers that I have is that success in endoscopic sinus surgery is not one phase. You need to have both a planning phase in the preoperative stage about evaluating patients and how do we prep them for surgery appropriately. Some tips about execution of sinus surgery, about what we need to do to execute sinus surgery well, and then thinking about how is it going to heal. All three of those phases are critical. If you aren't thinking about any of them, I think you're missing an opportunity to improve your outcomes. What I will say is that success in endoscopic sinus surgery is a vast topic. There's not one right way. I'm going to tell you my way, but I think as long as you have a plan and a rationale for each of those three phases, and I'm going to talk through some of the practicals of my plan and the rationale. The first one is that we need to understand that chronic rhinosinusitis is not one disease. You know, we moved from 2012 when the European position paper would have came and told us that, well, you can break down sinusitis into with polyps and without polyps. And although the suggestion there makes sense, that when we move to 2020 and start to see that there are whole other host of problems that are sinusitis, both primary and secondary. The causes of those can be autoimmune or inflammatory. And we focus in on this diffuse inflammatory pathologies, which are either driven by type 2 pathology, eosinophilic, and polyp driven by the most part, at least in our part of the world, or non-type 2 in the non-eosinophilic. And I'm going to try to make that distinction because I think if we understand that, that goes a long way about what are the treatment paradigms we use. The idea being that the eosinophilic CRS is these watery polyp patients with not a lot of the chronic superinfection. The neutrophilic population is kind of that opposite, the one that is given by more of the foul discharge within the nose, crusting, mucus production, understanding that they're not usually this dichotomous. Usually there's a huge mixed population in the middle, and so some of them need treatments that are tailored to both. How can we figure out those patients when we're in the office and in the operating room? Well, there are ways, things on history, endoscopy, that help us figure out who those patient populations are and why. I've tried to circle out these about a paper that's from Canada, which I really like, that it talks about some of the features of the eosinophilic chronic rhinosinusitis patients. These are the young patients, comorbid asthma, who present with significant polyps and a reduction in their sense of smell early. When we look at those histology under the microscope, a lot of the eosinophils in the tissue and maybe in their blood. As we compare them to the older population with less frequent comorbid asthma that are really complaining of that foul smell and discharge, the mucopurulent discharge. If you can break those up, those are the ones that macrolide therapy is quite effective in. And so we're going to talk a bit about how separating these in your mind helps you tailor your treatments. You did see histopathology. I'm showing here a sheet of what we do for our histopathology at the University of British Columbia. All the tissue we take out at endoscopic sinus surgery, we get these kind of answers. Instead of getting a pathology report that says evidence of chronic inflammation. I was like, well, I knew that. I already knew that. What I needed to know is, what's the eosinophil count? What's the neutrophil count? What about basement membrane thickening, squamous metaplasia? Some of those markers that this disease is advanced and going to create problems for this patient in the future. I like this slide because this is a great takeaway slide about what I think about when I understand separating those patients into the eosinophilic population on the left-hand side of your screen or the neutrophilic or non-eosinophilic population on the right-hand side of my screen, is that both of them can benefit from saline nasal irrigations with or without steroids within them. But then the other treatments are different. The patients who are eosinophilic predominant are the ones that we can add things like advanced delivery devices to get more steroids inside their nose. Topical antihistamines, we know that things like sprays like Dymista combined with intranasal corticosteroids work for these allergic type populations. These are obviously the ones where aspirin desensitization and moreover now biologics work for. But giving biologics to the wrong side of this arm would be a mistake because I don't think you're going to get the success you want. That other side of the equation with the foul-smelling discharge, mucopurulent drainage, those are the ones where the long-term low-dose antibiotics work and make a big difference. In addition, things like impregnating your rinses with betadine or mupirocin, something that is attacking that chronic infectious piece is really where we're driving. So I like this slide because it's a good takeaway. The good news is that both of these sides of the equation benefit from comprehensive sinus surgery. And so that's where we're going to start with a couple concepts and a couple tools that I think are going to help us get there. First concept about tailored preoperative medical therapy, that if I can identify which side of this spectrum you're on, it's going to change what we do from a targeted medication standpoint. It means that we're going to treat these patients differently because we know that the different drivers of their disease are different. Some of these I think are important. I put it into a graphical way so that you can get a picture of that, is that in the eosinophilic population, we give them prednisone and antibiotics before surgery, at least I do, some of my colleagues do not. And I use antibiotics in the postoperative period, but for a short period of time. I may or may not use way more prednisone and taper it because I know that that prednisone has such a substantial effect on the eosinophilia that marks this disease. In that neutrophilic population, I start them on antibiotics way before surgery and continue it quite a bit after surgery because this is the targeted population where we can even drop the dosing of that macrolide therapy and continue it for quite a bit longer. And so you'll see those are patients that I keep on oral antibiotics for 3 months postoperatively, potentially. Here's the next concept. It's comprehensive sinus surgery. All of this, when we're talking about surgery in the sinuses, is predicated on the idea that we need to be comprehensive at surgery time. What does that mean? That means removal of all the partitions within that ethmoid cavity to skeletonize the orbit and the skull base. Schematically, what that looks like, I think, is thinking about all those partitions without removing the turbinates. We want to remove all those ethmoid partitions. When we look at it in a sagittal plane schematically, we're saying that it may be enough to put holes into each of these sinuses and let medication get in there. But the problem that happens is medication getting there? Have we maximally removed the surface area for those polyps to grow? Have we created a situation where it may scar closed and create places where polyps can continue and inflammation can continue to drive? Wouldn't it be better for us to comprehensively remove these septations, flush with the skull base and the orbit, so that we maximize our topical medication delivery and allow for better outcomes? This is a nice patient that I met about 8 years ago at surgery and then had a 5-year scan after surgery. She had extensive eosinophilic sinusitis, and I removed the entirety of the partitions along her orbit and her skull base. She came back because she was in a car accident and had a scan through the emergency department, and I got this scan. It shows comprehensive removal of those partitions and aeration of the entirety of her sinuses with medication penetration throughout. And I think if we can do that over and over and over again, it's how we achieve these kind of long-term outcomes. People who get great results at surgery and then continue to maintain those great results with topical therapies. I'm going to talk about how I do that. I have some pearls and tips that hopefully the remainder of the speakers are going to piggyback on and show you in the lab as well. The first one that I do is extended uncinectomy. You think about, this is the first thing that we all perform at surgery. What does that mean to do it in a comprehensive or extended way? We know that the uncinate process guards that front door to the sinuses. And so what I tell the residents and fellows when they work with me is that, you know, we need to remove that in its totality, but we actually want to, the way we know we have is we want to see 3 things. We want to see the orbit once it's removed. We want to see the natural ostium of the maxillary sinus inferiorly, and we want to see the frontal sinus drainage pathway, at least the base of it. And so when we can do that, we know that we've removed enough of that. And when we remove an additional part, either superiorly or superolaterally, I call that an extended uncinectomy. The rationale behind an extended uncinectomy is it gives me more room, opens the front door to the sinuses further. I've coined a term about the lateral beak. The extension of the frontal beak onto the lateral wall of the nose anteriorly is this bone. That bone houses the nasolacrimal duct, but also blocks the front door of the sinuses. what happens is that you can't get your instruments onto the anterior portion of the lateral part of the ethmoid cavity or the orbit. If we remove that bone, we find that that trajectory changes and we can get our instruments and our scope right onto the orbit. And that's how we can skeletonize the orbit wall and not leave behind septations and areas for growth, regrowth of polyps. It means that when we do that, what that looks like is removal of that uncinate. And I do this in a very specific way because I want to keep that tissue, something I'm going to come back to in the next couple minutes. And when removing that, keep a large piece for use for later, which we'll talk about. And then I'm going to go back and address and make sure that I can go there and see the natural ostium in the maxillary sinus right off the hop. I can work on this lateral beak area, and I'm going to show you how I do that a little later, so that I can look directly into this and see that I'm in the frontal recess immediately, ready to work on my frontal sinuses later, and that I'm skeletonizing the anterior orbit. And when I see that done in the operating room, we maximally open the front door to the ethmoid complex, and that's what that looks like. That having that much room to work improves our ability to do a good job. When I can get light in there and I can get instruments in there, my life has gotten a lot easier right away. And when we see that happen, we can see what that happens in a healed way. By doing that, I improve visualization, I improve my ability to be comprehensive, and I improve my flushability of that cavity. We got to make sure that we mitigate the risk associated with what happens to what the body tries to do, which is close that after surgery, and I'll talk about that tomorrow, and risk to the orbit and the nasolacrimal duct. We have to do that without injuring the orbit and nasolacrimal duct, and hopefully I'll show you some pearls. But when you do that, that's how you get these postoperative openings into the middle meatus, where you can see the orbit, maxillary sinus, sphenoid sinus, and frontal recess all in one view. And that's exactly what we want to do to try to improve outcomes. And it started with the very first step at surgery. I'm going to go back one, which is that there are other steps that I think that we can easily tailor and change and that improve our ability to do good surgery. One is that we got to see better. And the ways that that happens is positioning yourself well in the operating room. We have long careers ahead of us. And so our ability to be able to do that is dependent upon being safe. Positioning the head of the bed up. If you can find a way to make the head of the bed elevated, your ability to see from the blood loss standpoint goes way down. Packing the nose with things like 1 in 1,000 adrenaline, pretty well established at this stage. That the safety of that is pretty well understood, that that's just going to help you see. And if you see better, you're going to do a better job. And warm saline irrigations. I have a slide on each of these, but I think that we've covered the idea that bleeding is going to be the antithesis of doing a good job. Your incidence of complication and injury goes way up when you can't see. And so anything you can do to improve the visual field you have is going to lead to better outcomes. This was the ergonomics I talked about, head of bed elevation, packing the nose with topical adrenaline, either before surgery and or immediately at the start of surgery. I additionally inject the nose with that, and I have a bit of a video about injection and packing that maybe makes it a little bit more understandable. I don't think the injection helps me with blood loss. I really don't think, although I inject with lidocaine with epinephrine, I don't think it helps me with blood loss. What it does do is it helps with the postoperative pain in the recovery room, and so I think that it helps substantially. I inject along the anterior part of the maxillary line, and then you'll see me pack into that space directly. And so I'm going to take a patty and put it directly into that middle meatus. And you can see that by our ability to be able to stuff those up into that middle meatal space is what's going to get decongestion before we even start surgery. And then warm saline irrigation is pretty well established that takes the red out of the field and allows us to see better. The next concept that I have is about think septum, do septum. The idea that the rationale behind performing septal surgery can be multifold. I have a million reasons I could tell you to combine septal surgery with your endoscopic sinus surgery. The most notable of them is that if you can see better and you can deliver medications better after surgery, your outcomes are better. I'm not going to belabor some of the points of seeing what happens after you do that, but I am going to lean on some of the data that if you can move the septum while you're doing it, now I can make the left side big while I'm working on the left side, or I can make the right side bigger when I'm working on the right side. That septal mobility, particularly when you're starting to use angled instruments for the frontal recess, becomes so tantamount to doing a good job. The ability to have more space seems worthwhile. Furthermore, that we know that the data shows us that no matter what the reason, you did that septal surgery because you wanted better access to the frontals, because they had a bent septum, because there was an additional, those people have a 10-point further improvement in SNOT-22 scores. That is pretty impressive if you have, without even knowing the reason they did it. Just by doing it at the same time as sinus surgery, they get better outcomes. I'm not going to show another case about showing the proof behind that, but the idea is that think septum, do septum. If I have any reason to do that, I'm going to address the septum at the same time. Mucosal preservation. The difficulty becomes that when we go into sinus surgery, we're using a whole host of tools, and the problem becomes preserving the mucosa that needs to stay behind is hard. And you sometimes don't even notice that the mucosa gets lost very quickly. Unfortunately, the loss of the mucosa on the orbit and skull base in this situation leads to an intense inflammatory reaction, an osteotic reaction of the bone, a deposition of granulation tissue, hyperostotic bone formation, and scarring and closure of the sinuses. And so it takes a while to figure out to see that happen, but once you can see that happen, that you start to realize that that's exactly what leads to trouble in surgery. And that trouble is what we're trying to avoid, because if you've ever seen someone who's had previous sinus surgery and they end up with these things, these hyperostotic pyramids of bone, that's why it happened, is stripping in the operating room. Fortunately, in this case, it's in a place where it's not blocking anything. It's not blocking frontal sinus drainage, it's not blocking the sphenoid. What, unfortunately, sometimes that happens. Same patient, left and right scan. This is their preoperative scan, sadly done elsewhere, and you could ask us what was the degree of disease there. Postoperatively, someone has stripped all the lining off these cells without removing them. And then you've gotten that hyperostotic bone reaction and a frontal sinus mucocele as a result when I met this woman. What I do to mitigate that mucosal loss is it's going to happen. It's not possible to use a microdebrider and never strip mucosa. But what we can do is do some things to try to improve it. That's why I took that uncinectomy process out in one piece and on the back table fillet it, take off that mucosa to create a 1 by 2 centimeter piece that at the end of surgery, if I have any areas where I've lost mucosa, that I put those directly back onto. And that aids cover that bone to not have that intense inflammatory osteotic reaction, the granulation tissue that comes with it. The pain, when you have patients who tell me after surgery when I move around my eyes it hurts, that's from that bone being inflamed. Here's on the skull base, putting that mucosa in several different scenarios where we've lost mucosa to try to get an improvement healing of that. I'm going to try to go quickly through some, so I'm going to skip some of my concepts. One of the next ones is about the right tools. I think that very similarly, we've got to understand the difference between through-cutting instruments and grasping instruments. We want to cut the things we want to cut. We don't want to grab and pull anything, because anything you grab and pull comes with its mucosal lining, and sometimes the mucosal lining of the orbit and the skull base. So all through-cutting instruments, graspers are only for things that are floating around inside the nose that need to be removed. That means that when you grab and pull, you're going to peel the mucosa with it. When you cut, you're going to cut the septations flush and leave the mucosa on the skull base or orbit, as the case may be. And then there's all different angles and versions of through-cutting tools for frontal sinus surgery. And then the one tool that we use the most in sinus surgery, the best and the worst tool in sinus surgery, is the microdebrider. But we got to be careful about what is the problematic part of the microdebrider. It's the suction. The suction allows us to see, but it also sucks in mucosa, lamina, orbital fat, medial rectus muscle. All the injuries come from the suction. So turn down the suction if you're having trouble. I use the Neptune in my OR now. This has been a game changer because I can dial it by millimeters of mercury. I want 400 millimeters of mercury when there's thick fibrotic polyps that are plugging my microdebrider. I want 200 millimeters of mercury when the mucosa wants to strip and come into it. I also additionally do something unique, which is that I sometimes run the microdebrider in the forward mode, like it was the drill. What it does is it minimizes the time that it has to be in suction, and so it doesn't let it suck tissue in. It creates less mucosal damage. You just do that by using the foot pedal on the microdebrider. It turns it from the oscillating mode at 5,000 RPM, going back and forth, to spinning forward at doing that. The only advantage of it is that it allows me to address areas with less suction. Without asking someone to turn down the suction, I can quickly go to address hyperostotic bone in the ethmoid complex without the mucosa of the orbit coming with me. I know I need to take that shelf down further, but I can see that the mucosa wants to try to strip. And so I'll stop when it's starting to just strip away, and say, okay, I'm just going to work on that bony piece. And you can see the mucosa kind of getting tethered, but not stripping off like it would when it was in the microdebrider. I'm going to skip this part because it was about how I use that same technique on hyperostotic septations, those firm ones that make you have to stop with your microdebrider and use a different tool like a Kerrison, but a Kerrison doesn't have suction. So the microdebrider on drill mode is my Kerrison on suction without having to change tools, not speeding, continuing to speed through that process. I'm not going to belabor that, but it's just the same concept about using that as a tool for me. When the microdebrider you'll see bouncing off of things, it doesn't happen when we start to use the microdebrider in the drill mode. It starts to allow us to get much better aeration of those sinuses. The last concept that I think I have is about angled endoscopy. I want to kind of reinforce the idea that there's a lot of things you can do with the straight endoscope. There are some things that you need to at least examine with an angled endoscope, which gives you an off-axis view, most notably the maxillary and frontal sinuses. And so the idea becomes that when you're using a xeroscope, when we've done our uncinectomy, sometimes we can't get in. We can see a posterior accessory ostium in the back, and sometimes we're not, is that the natural? Here's a 30-degree view of the same patient where we come closer and we've seen that was a posterior because the natural ostium is actually behind that uncinate process and tucked in. And then when we go to use a 70, you can see how obvious it is that was a posterior accessory ostium, and just enlarging that would lead to constant recirculation. Having the ability to at least examine it with an angled endoscope, if not do the maxillary sinus work with the angled endoscope, I think is important. That concept still applies to the frontal sinuses. You see that when we see the frontal sinuses like this with the agranesi in place and posterior cellularity in place as well, that I'm going to skip this part, that we want to remove that. When we're looking in with a 0-degree endoscope, even if we've done a nice job of removing the axilla of the middle turbinate, you're not really getting a great view into the frontal sinus. And so maybe a better way would be using an angled endoscope to look directly up into it. It changes the view we get here, having to use our brain to realize, yeah, that's the frontal recess, to this kind of view, where we're looking right into the frontal sinus and keeping in mind that we're going to see the posterior fable of the frontal sinus. It means that when we go back and look at that, practically speaking, what does that look like? Well, this is the end of surgery where I've done comprehensive sinus surgery, maxillary sinus, ethmoid, sphenoid, and we're going to come back and look at the frontal. I can tell that I'm in the frontal recess there, and I think it's open, and the same thing happens on the opposite side, that I think that frontal is well opened, but I will tell you that do I know that that's open? The difference when you look with a 70-degree scope or 45 or 30 or whatever you're comfortable with is look at our ability to see right into the frontal sinus to determine that the entirety of the boundaries of that frontal recess have been skeletonized. And so it's the difference between knowing you're at the frontal recess and seeing directly into the frontal sinus. The last concept I have about frontal sinus surgery is very similar in that a case for a funnel, not a tunnel. I'm going to try to describe that instead of using the words, is that we know that's the frontal sinus outflow tract. We know if we're going to try to do a bulla intact frontal sinus procedure, we're going to create this tunnel into the frontal sinus. I would advocate for us to remove the entirety of those septations and create a funnel-shaped opening. And moreover, maybe we need to remove a part of that frontal beak so we can expand that funnel. Again, in a different case, frontal sinus there, frontal sinus outflow tract with the bulla intact, frontal sinus outflow tract with skeletonizing the posterior table of the frontal sinus. And what you're always going to find by doing that is you're going to identify the anterior ethmoid artery. We can see its nippling on CT scan. When we skeletonize it in the OR, it sits at the back end of our frontal sinus dissection. I call this the tail of the horseshoe. It sits right at the tail of the horseshoe. And so we can continue to see that if we have identified that spot, that is the anterior ethmoid artery in all cases, a key to making sure that we've comprehensively aerated the frontal sinus. There, zoomed in, another case of the same thing that I'm going to speed through a little bit just to show the anterior ethmoid artery can be always identified, and when it's on a mesentery is even easier to identify. I similarly wanted to make a note that this is an opportunity for us to talk about how you have to have angled tools to do that. And there are a million different tools that you could have. Unfortunately, they're expensive. And so the great equalizer in my situation is using an angled microdebrider because it can cut in 360 degrees, or having an instrument that can cut in 360 degrees like a Hoseman punch for the frontal. And I think I'm going to leave that for our frontal talk to talk about. So I wanted to give us a flavor of some of the concepts that I use to try to get to comprehensive aeration of the sinuses and healing cavities to get to the place where we're going to get great outcomes for our sinus patients. I'm trying to keep it to time, and I'll make sure I open up the last piece for any questions that we have. Good. Yes.
So obviously, if you remove a lot of turbinates, which you don't do, then you're at risk for that empty nose syndrome. But when you do these really comprehensive ones, do you get any of that kind of empty nose sensation for the patient?
That is not my experience. What I would tell you is that I think what's happening when you have empty nose is really an inferior turbinate phenomenon. That resistor for the nose at the anterior portion of the nose, internal nasal valve, is coming from the anterior head of that inferior turbinate. Moreover, the patients that we're operating on here have a global inflammatory condition. What I'm really trying to do at comprehensive sinus surgery time is remove the inflammatory load. This is a removal of the amount of mucosa that's there for that inflammatory burden to be on. We want to leave behind the things that have a function. The inferior turbinate, as you alluded to, for a resistor for the nose. The middle turbinate for olfaction. You saw that it was always intact there. Everything else there really can go. The things that don't have a warming, filtering, humidifying, resisting, or olfactory sensation for the nose can go in the garbage. We want to try to create aeration as a result.
I guess I'm going to say something that's controversial because that'll be fun, I guess.
Yeah.
What if the uncinate process actually serves a function? And what I'm saying is this. You've got a garden hose. You put your finger over the garden hose, and as you close it more and more, it starts to shoot the water through. So as you blow your nose forward and air is going through your nose anteriorly, it gets caught between the uncinate process and the osteomeatal complex, and it channels it down like a funnel into that frontal sinus, causing shearing forces, directing the airflow all along the periphery of that maxillary sinus and delivering snot. That is why, I think, when you want to blow your nose, you blow your nose, and you blow for a few nanoseconds, and suddenly it catches and delivers a big glob of snot. I think the uncinate process is part of that, physics and airflow. And I'm not saying not to do that. It's really cool, beautiful presentation. Access is great, and like you say, managing inflammation. I get all that, but I'm just wondering out loud, just to make it spicy in case anyone has anything to say about it all, that maybe we should be saving at least some of the uncinate process, and maybe there is some function to it. You leave these big MIG antrostomies, and people have different kinds of problems. I feel like they can't clear some of this. We always see beautiful results here, but we've all seen it where you've done a big maxillary antrostomy and there's still some dependent disease. I wonder. So I wondered out loud since I have an expert here.
I think you have some great comments, and what I won't do is belabor this discussion because we want to try to keep to timing. I'm going to answer yours throughout the course of the weekend because I think you have some good points there. Ones that the parts that I would focus on are that I think we have to understand what the disease process is. I have no doubt that every part of the human body has a function, whether vestigial or not. There is some function that was there. But I think we're in a diseased pathological state, and I'd say in that situation, the uncinate is not doing you any favors.